Welcome. In this session, we'll discuss classification, risk factors, pathogenesis, and pathology of age-related macular degeneration or AMD. And in the next session, we'll discuss diagnosis and management of non-neovascular AMD and that of neovascular AMD in the subsequent session. AMD is a progressive degenerative disorder of retinal pigment epithelium and photoreceptors, which is characterized by extracellular deposits beneath the retinal pigment epithelium and or the retina, as seen here in this diagram, with this being the retinal pigment epithelium and this being the Bruch's membrane, which leads to either atrophy of the retinal pigment epithelium, retina, and the choriocapillaries, as seen here in this clinical photograph, or neovascularization in the choroid and or the retina, as seen here in this clinical photograph, and the corresponding fluorescent angiogram. These deposits arise from residues of metabolic processes which are essential to photoreceptors and retinal pigment epithelium, and the deposits are thus secreted by the retinal pigment epithelium and the photoreceptors, mainly in the subretinal pigment epithelial space but also in the subretinal space. The deposits accumulate in this area when there is imbalance between production of these deposits by the retinal pigment epithelium and the retina and clearance of these deposits through the Bruch's membrane and into the choriocapillaries. The accumulated deposits decrease transfer of nutrients to the retinal pigment epithelium and the retina from the choriocapillaries, and this leads to production of vascular endothelial growth factor from these hypoxic retinal pigment epithelial and retinal cells, with this vascular endothelial growth factor promoting macular neovascularization or the decreased transfer of nutrients to the retinal pigment epithelium and the retina leads to atrophy of these tissues. AMD is a leading cause of irreversible vision loss worldwide in older population and is the leading cause of irreversible vision loss in developed countries. In 2014, a meta-analysis of all population-based studies estimated that 8.7% of the population worldwide had some form of AMD, and the estimated number of people expected to have some form of AMD by 2020 is 196 million and by 2040 is 288 million worldwide. AMD progression is typically classified into two phases, the early phase of AMD and the late or advanced phase of AMD. The early phase of AMD is also called early non-neovascular or early dry AMD and is characterized by Drusen's and retinal pigment epithelium changes as seen here in this photograph. And the late or advanced phase of AMD can be of two types. One is the advanced non-neovascular or advanced dry AMD characterized by geographic atrophy as seen here in this photograph, and the other is the neovascular or wet AMD characterized by macular or choroidal neovascularization as seen here in this clinical photograph and the corresponding fluorescent angiogram. Currently, the term macular neovascularization is preferred over choroidal neovascularization to include type 3 pattern of neovascularization, and these two forms of late AMD may coexist in the same eye. Alternatively, we may classify AMD into a non-neovascular type, which is characterized by Drusen and RP changes in the early phase and geographic atrophy in the late phase, and a neovascular type, which is characterized by macular neovascularization. The most commonly diagnosed form of AMD is non-neovascular AMD with either Drusen's or geographic atrophy, and this pattern progresses slowly over years. But the most common cause of severe visual loss from AMD is neovascular AMD, which contributes to 85% of severe visual loss from AMD and usually occurs rapidly within weeks. Geographic atrophy or the advanced form of dry AMD is a less common cause of severe visual loss from AMD and contributes to 15% of severe visual loss from AMD. Demographic, environmental, and genetic risk factors cause inflammatory damage to the various layers of the central macula, which leads to the advanced forms of AMD, either geographic atrophy or macular neovascularization. Among the non-modifiable risk factor, age is the strongest demographic risk factor, and so the name age-related macular degeneration. And the incidence of AMD changes increase with age, particularly over 65 years of age. AMD is more prevalent in whites as compared to blacks, and the prevalence in Asians and Hispanics is intermediate between whites and blacks. And there is some evidence of higher incidence of AMD in females. Other non-modifiable risk factors of AMD include hyperopia, and we may note here that myopia may also predispose to choroidal neovascularization, but this is not considered to be age-related in type. Light iris color and elevated levels of C-reactive protein and other inflammatory markers are also considered to be non-modifiable risk factors of AMD. Family history of AMD predisposes an individual to AMD, and it has been found that monozygotic twins have a higher concordance rate of AMD as compared to dizygotic twins. And first-degree relatives of AMD patients have a higher incidence of AMD as compared to first-degree relatives of control individuals. We'll discuss genetic predisposition to AMD in further detail. Genetic factors are said to contribute to 55% or more of the total AMD risk in an individual, and more than 34 genetic loci on more than 19 chromosomes have been identified on genome-wide association studies to increase the risk of AMD. And the genetic risk factors have been found to be involved in various biochemical pathways, among which the complement pathway is the most important and the most consistently implicated genetic risk factor of AMD. Polymorphism of the gene for complement factor H is a major susceptibility genetic factor for AMD and is linked particularly to geographic atrophy. But polymorphism of genes linked to other complement components have also been strongly linked to AMD. Among the components of extracellular matrix metabolism, genetic mutations in ARMS2 HTRA1 locus is the other major susceptibility gene for AMD, linked particularly to neovascular AMD. But mutations in other genetic loci involved in extracellular matrix metabolism have also been found to increase the risk of AMD. And other genes whose mutations have been found to increase the risk of AMD are those for apolipoprotein A and hepatic lipase C in the lipid transport and metabolism pathways, ATP binding cassette protein involved in retinol metabolism, and vascular endothelial growth factor A, which is involved in angiogenesis. But routine genetic testing for susceptible individuals is not yet recommended. Among the modifiable risk factors, smoking is the most well known, and this is very important to remember. And both active and past smokers have increased risk of AMD. Smoking causes a large number of pathogenic insults such as vascular inflammation, endothelial dysregulation, oxidative damage, reduced antioxidant levels, reduced HDL levels, and increased platelet aggregation. But alcohol consumption is not considered to have a large effect on development of AMD. Dark green leafy vegetables, which are high in lutein and zeaxanthin, lower the risk of AMD, and so does consumption of fish, which is rich in omega-3 fatty acids. Mediterranean and Asian diets reduce the risk of AMD, whereas Western diet increases the risk of AMD. High fat intake, whether saturated, polyunsaturated, monounsaturated, or trans-unsaturated, increase the risk of AMD. Higher BMI, abdominal obesity, and in men, increased waist-hip ratio increases the risk of progression to late AMD, and occurrence of atherosclerotic plaques have been shown to be associated with the risk of AMD. But association of AMD with LDL and HDL levels is inconsistent. Use of statins decrease the risk of AMD. Hypertension and cerebrovascular disease have been associated with the risk of AMD, but there is no consistent association between diabetes and AMD. But metformin, which is used to control diabetes, decrease the risk of AMD. Elevated levels of C-reactive protein and other inflammatory markers such as interleukin 6 have been associated with the risk of AMD, and the components of the extracellular deposit in the sub-RPE space contain pro-inflammatory mediators which damage the Bruch's membrane and induce angiogenesis. Postmenopausal estrogen and progestin therapy have been found to reduce the incidence of early and late AMD, but long-duration OCP use increases the risk for late AMD. And among drugs, current recommendation is to continue aspirin therapy when a patient on aspirin is diagnosed to have AMD. And as we have discussed, statins and metformin decrease the risk of AMD, and statins are said to decrease the risk of AMD through their anti-inflammatory and antioxidant functions. And the association of increased exposure to light and AMD is inconsistent. Coming to the pathogenesis of AMD, as we have discussed in the session on RPE and Bruch's membrane, incompletely digested products of photoreceptor outer segment metabolism which occurs in the RPE cell are either retained within the RPE cell as liposuction granules or secreted into the subretinal pigment epithelial space. And from there, the secreted material is cleared through the Bruch's membrane into the choriocapillaries. With age, Bruch membrane thickening occurs when normally secreted RPE products are not cleared efficiently from the subretinal pigment epithelial space. And this happens when the retinal pigment epithelium and the retina, which produce these deposits, are more functional than the Bruch membrane and the choriocapillaries through which these deposits are cleared from the subretinal pigment epithelial space. And Drusens are accentuations of these thickenings which are clinically visible. The thickened Bruch's membrane and these deposits impede passage of fluid and nutrients through it, causing relative ischemia of the retinal pigment epithelium and the retina, leading to release of vascular endothelial growth factor A from these tissues. And vascular endothelial growth factor A promotes ingrowth of neovascularisation, which most commonly originates from the choroid but can also originate from the deep capillary plexus of the retina. The deposited lipid derivatives, being pro-inflammatory and cytotoxic, damages the Bruch's membrane, thus promoting migration of these new vessels through the Bruch's membrane into the sub-RPE space. And since this deposit is thickest in the center of the macula, neovascularization also tends to occur in the center of the macula. And the decreased availability of nutrition from the choriocapillaries due to these deposits and fibrosis and calcification of the Bruch's membrane lead to atrophy of the retinal pigment epithelium and the outer retina. And when the overlying RPE atrophies, terminating the source of these deposited materials, the Drusens may collapse. RPE atrophy can also occur following macular neovascularization. Histopathological examination helps in understanding the disease process, but it is often not possible to correlate clinical findings with histopathological findings, because some lesions such as Drusen components may be lost during tissue processing for histopathological examination, and some lesions such as basal laminar deposit and basal linear deposit, which are consistent pathological features of AMD and which we will discuss further, are not apparent on clinical examination. We will first discuss histological features of age-related changes in the central macula and then discuss the pathological features of age-related macular degeneration, but often a clear distinction between these two, age-related histological changes and AMD pathological changes, is difficult. To discuss the age-related changes, we will refer to two diagrams, one representing the histological features of the central macula of a young individual and the other representing histological changes in the central macula of an aged individual. With age, there is reduction in number of photoreceptors and rods are more severely affected than cones, and the outer segments of photoreceptors become disorganized and convoluted due to impaired phagocytosis by the retinal pigment epithelial cells. In the retinal pigment epithelium, with aging, there is reduction of the number of melanin granules, but there is increase in the number of liposuction granules as well as melanolysosomes and melanoliposuction granules. The chief source of liposuction granules are the phospholipids and proteins of the disc membranes of photoreceptor outer segments, and when these phospholipids and proteins undergo oxidative damage and are engulfed by the retinal pigment epithelial cells, the retinal pigment epithelial cells fail to degrade these oxidatively damaged phospholipids and proteins, and the residual undigested material accumulate as liposuction in residual bodies. Liposuction granules can also arise from free radical induced damage of lysosomal enzymes within the retinal pigment epithelium, such as cathepsin D, autophagy within the RPE cells, and materials accumulated from dead photoreceptors and adjacent dead RPE cells. In the Bruch's membrane, with aging, there is accumulation of lipids, and lipids are one of the major contributors to age-related increase in thickness of Bruch's membrane, and the lipid in Bruch's membrane is found within coated membrane-bound bodies and also free within the Bruch's membrane. And the lipids accumulating in aging Brooks membrane consists of free cholesterol, phospholipids, triglycerides, and fatty acids. The chief source of lipids accumulating in an aging Brooks membrane are cholesterol-rich lipoproteins, which are sourced from the choriocapillaries and act as carriers of various nutrients for photoreceptors such as vitamin A, vitamin E, lutein, and zeaxanthin. And when these nutrients are transported to the photoreceptors, the carrier lipoproteins are deposited in the Brooks membrane. Another source of lipids accumulating in an aging Brooks membrane are peroxidized lipids, which are derived from long-chain polyunsaturated fatty acids in the outer segments of photoreceptors, and these are pro-inflammatory and cytotoxic in nature and are very important in the pathogenesis of age-related macular degeneration. Lipids accumulating in an aging Brooks membrane can also originate from fatty acids and unesterified cholesterol, which are absorbed by retinal pigment epithelial cells directly from choriocapillaries and then deposited in the Brooks membrane. Calcification of Brooks membrane also occurs with age, particularly in the middle elastic lamina of the Brooks membrane, and other materials such as advanced glycation end products and complement components can also get deposited in an aging Brooks membrane. So there is an age-related increase in Brooks membrane thickness, and this increase in thickness is maximum in the outer collagenous zone of the Brooks membrane and minimal in the inner collagenous zone. There is no significant change in thickness of the middle elastic lamina of the Brooks membrane. On transmission electron microscopy, this increase in thickness of Brooks membrane appears to be due to deposition of coated membrane-bound bodies, increase in the amount of collagen in the Brooks membrane, and mineralized deposits. And the major contributor to the increase in thickness of the Brooks membrane on transmission electron microscopy are coated membrane-bound bodies, as shown here in this diagram, which contain lipoprotein particles and are found in the outer collagenous zone and the inner collagenous zone of the Brooks membrane. With aging, there is also a general increase in the amount of collagen in both the outer collagenous zone and the inner collagenous zone, and the collagen getting deposited in an aging Brooks membrane appear banded on transmission electron microscopy, and so is also called fibrous long spacing collagen. As we have described, mineralized deposits also occur in the Brooks membrane, particularly calcium, which gets deposited most commonly in the middle elastic lamina of the Brooks membrane. With these deposits and increase in thickness of the Brooks membrane, the hydraulic conductivity or the permeability through the Brooks membrane decreases with age. With age, there is also a reduction of vascular density in the choriocapillaries, and this is the most prominent aging change in the outer retina RPE choroid complex. The choriocapillaries density decreases with loss of endothelial cells, and there is also a decrease in diameter of the choriocapillaries lumen. The choriocapillaries walls also appear thickened and hyalinized. With aging, the appearance of larger choroidal vessels change little, and these larger choroidal vessels are more prominently visible on clinical examination because of reduction in the vascular density in the choriocapillaries layer. And despite an increase in thickness of the Brooks membrane with aging, there is an overall decrease in average choroidal thickness with age. We'll discuss the pathological features of AMD with the help of these two diagrams depicting the histopathological changes in early AMD and advanced AMD. Along with degeneration of the retinal pigment epithelium, basal deposits are the histopathological hallmarks of AMD, and this is very important to remember. And two types of basal deposits are known to occur along the RPE basement membrane. One occurring anterior to the RPE basement membrane called the basal laminar deposit, and the other occurring posterior to the RPE basement membrane known as basal linear deposit. These deposits are not visible on ophthalmoscopy, are difficult to differentiate with light microscopy, and definitive identification and differentiation requires transmission electron microscopy. Basal laminar deposits occur between the RPE cell and the RPE basement membrane, and they can be detected with light microscopy and are the hallmark of AMD on light microscopy. They consist of granular lipid-rich material with extracellular matrix proteins, mostly widely spaced collagen fibers. Small patchy areas of basal laminar deposit is considered as part of normal aging process, but a continuous and or a thick layer of basal laminar deposit is consistent with age-related macular degeneration. And focal elevations of basal laminar deposit are called basal mounds and are not Drusens, which occur posterior to the RPE basement membrane along with basal linear deposits. Basal linear deposit is a thin layer of deposit between RPE basement membrane and inner collagenous zone of the Bruch's membrane. They are not visible on light microscopy and can be detected only with transmission electron microscopy. They are made up of membranous debris and vesicles composed mainly of lipids. Soft Drusens arise from basal linear deposit and are the clinically visible portion of basal linear deposit. Basal linear deposit are said to decrease adherence between retinal pigment epithelium and the Bruch's membrane and are said to create a space where retinal pigment epithelial detachment may develop and neovascular networks can grow. Membranous debris, which I have just mentioned as occurring within basal linear deposits, are solid lipid particles, and in addition to basal linear deposits, membranous debris are also found in basal laminar deposits and anterior to retinal pigment epithelium associated with subretinal Drusenoid deposits, which we will be discussing later in this session. Membranous debris in any location are the hallmark of AMD on transmission electron microscopy. So these basal deposits start occurring before Drusens are clinically detected, and basal linear deposit is most consistently associated with clinical and histopathological age-related macular degeneration, and this is important to remember. As we have discussed in the beginning of this session, Drusens and RPE changes are the clinical findings of early stage of AMD, and geographic atrophy and macular neovascularization are the clinical findings of late stage of AMD, and we'll discuss the histopathological findings of these lesions. Drusens appear as focal eosinophilic and PAS-positive deposit between the retinal pigment epithelium basement membrane and the Bruch's membrane. And among the various types of Drusens which have been described, the principal precursors of late-stage AMD, namely geographic atrophy and macular neovascularization, are soft Drusen and subretinal Drusenoid deposits, and this is very important to remember. Hard Drusen, as seen here in this clinical photograph, is considered as a normal finding and is not associated with age-related macular degeneration, and they appear as hyalinized globules between retinal pigment epithelium basement membrane and inner collagenous zone of Bruch's membrane, the site being the same as that of soft Drusens and basal linear deposits, and on electron microscopy they have an amorphous compact appearance. Soft Drusens, as seen here in this clinical photograph, appear larger and has less well demarcated margins, and also occur between retinal pigment epithelium basement membrane and the inner collagenous zone of Bruch's membrane. And electron microscopy of soft Drusens shows a coarsely granular structure with membrane bound globules of amorphous materials and lipid pools. Soft Drusens most frequently occur in the central macula, and soft Drusen predisposes to formation of macular neovascularization type 1, which occurs in the subretinal pigment epithelial space, which also thus tends to occur more frequently in the central macula. And this association of soft Drusen with macular neovascularization type 1 is very important to remember. And large focal accumulations of basal linear deposits, which tend to separate the retinal pigment epithelial cell from the Bruch's membrane, are called Drusenoid retinal pigment epithelial detachment. When Drusens tend to regress, usually due to atrophy of the overlying retinal pigment epithelium, both overlying photoreceptors and the retinal pigment epithelial cells thus tend to disappear. But the overlying basal laminar deposit remains intact, and macrophages invade the regressing Drusen and remove membranous debris. Material not removed undergoes gliosis by Muller cells or calcification. A large number of molecules have been detected in Drusens, including neutral fats, phospholipids, glycoconjugates, and complement components, but there are no specific histochemical patterns of different Drusen clinical phenotypes. Drusens are dynamic in nature, and their structure tends to change on a time scale of months to years. Drusens may resolve over time with or without atrophy of overlying retina. Drusens may undergo dystrophic lipidization and calcification to form calcific drusen, which appear refractile on ophthalmoscopy, and pigment-laden cells, which may be retinal pigment epithelium or invading macrophages lying anterior to the drusen, can migrate more anteriorly into the retina and appear as focal or reticulated clumps of intraretinal pigmentation overlying the drusen. And these intraretinal pigmentations are said to be a prognostic indicator of progression to advanced AMD. Then there are three other well-described patterns of drusen, among which subretinal drusenoid deposits, also known as SDD or reticular pseudodrusen, are located in the subretinal space instead of the subretinal pigment epithelial space, mostly in the superior macular area, as seen here in this clinical photograph. They are most commonly found along the arcades and also nasal to the disc, but very few are found in the center of the macula. They are found to be evenly spaced both on histopathology and on OCT, and consist of membranous debris with lipid interiors dispersed uniformly throughout a ground substance containing globular proteins. The lipid interior of subretinal drusenoid deposits contains only unesterified cholesterol, and subretinal drusenoid deposits are consistently associated with choroidal thinning and are highly associated with development of macular neovascularisation type 3, which arises from the deep capillary plexus of the retina and is very important to remember. Subretinal drusenoid deposits do not calcify, and they can be found in inherited retinal disorders other than AMD. Cuticular drusen, as seen here in this fundus photograph, are located between retinal pigment epithelium basement membrane and inner collagenous zone like hard and soft drusens, but are symmetric in distribution in the two eyes and tend to occur in younger individuals and are not related to AMD. Pachydrusen, as seen here in this clinical photograph, are associated with pachychoroid spectrum of diseases, which we will discuss in a separate session. And like hard and soft drusen, they occur between the RPE basement membrane and the inner collagenous zone of Bruch's membrane. Unlike soft drusen, they are associated with thickened choroid and have well-defined edges, and they tend to occur outside the central macula in single or isolated clusters. Pachydrusen are associated with polypoidal choroidal vasculopathy, also called aneurysmal macular neovascularization type 1. And it has been observed that subretinal drusenoid deposits and soft drusen, both of which are associated with thinning of choroid, can occur together in the same eye, but pachydrusen and subretinal drusenoid deposits usually do not occur together in the same eye, with pachydrusen being associated with thickening of the choroid and subretinal drusenoid deposits being associated with thinning of choroid. In AMD, there is continued accumulation of lipofuction and melanolipofuction, resulting in focal areas of hyperpigmentation. The basal infoldings and the surface villi also tend to disappear, indicating loss of phagocytic activity. The degenerate and dead RPE cells can migrate to the sub-RPE space, the subretinal space, or into the retina, and may discharge their granules, which may be taken up by surrounding RPE cells or deposited in the sub-RPE or the subretinal space. The RPE cells surrounding the dead RPE cells enlarge and migrate to occupy their position, resulting in focal areas of hypopigmentation, and when the remaining RPE cells can no longer fill the gaps, atrophy results. And as we have mentioned, loss of overlying RPE leads to progressive collapse of the soft drusen as the source of the deposits is eliminated. Other histological changes of RPE which may be found in AMD include bilaminar RPE, which is found more commonly in eyes with neovascular AMD as compared to eyes with geographic atrophy, and entombed RPE, which is present within scar tissue of neovascular AMD. With development of AMD, the hyalinization and thickening of Bruch's membrane continues and extends posteriorly through the intercapillary pillars between the choriocapillaries and may eventually surround the choriocapillaries. Some regions of Bruch's membrane may thin and breaks within the Bruch's membrane may develop. Chronic inflammatory cells may be found on the outer surface of Bruch's membrane in the space formerly occupied by choriocapillaries, particularly near the breaks in Bruch's membrane, and may promote migration of new vessels through these breaks. Geographic atrophy is a well-demarcated region of attenuated or absent retinal pigment epithelium with loss of overlying photoreceptors. The zone of photoreceptor loss is not as well demarcated as loss of RPE at the margin of geographic atrophy, and atrophy of outer retina. Overlying geographic atrophy due to loss of choriocapillaries in the region leads to gliosis by Muller cells adhering the neurosensory retina directly to the Bruch's membrane. In the region of geographic atrophy, there is loss of underlying choriocapillaries, and in long-standing cases, the Bruch's membrane in the region of geographic atrophy may become thin. Macular neovascularization is classified into three types. Type 1 macular neovascularization lies in the subretinal pigment epithelial space and originates from the choroid and breaks through the Bruch's membrane. It has a vascular system stemming from a trunk of feeder vessels, either originating from the larger choroidal vessels or from the choriocapillaries. The new vessels have leaky endothelium, and so the new vessels are associated with fibroblasts, myofibroblasts, lymphocytes, macrophages, as well as proteins and lipids. And as we have mentioned earlier, soft Drusens increase the risk of macular neovascularization type 1. And three structures have been described between the RPE and the Bruch's membrane, which corroborate with OCT findings of triple layered sign or multi-layered PED in a mature type 1 macular neovascularization. And these three structures are basal linear deposit, the new vessels themselves, and the fibrocellular scar. And maturation of fibrous tissue associated with type 1 MNV results in scar formation, which is accompanied by regression of the new vessels. Type 2 macular neovascularization lies in the subretinal space between the neurosensory retina and the RPE, and usually originates from a type 1 MNV extending anteriorly through the retinal pigment epithelium. Type 2 macular neovascularization can also arise from type 3 macular neovascularization extending posteriorly. Type 3 macular neovascularization, as shown here in this diagram, originates from deep retinal capillary plexus and can extend posteriorly to the subretinal or the sub-RPE space. They do not have any vascular connection with the choroid until late in the disease process. And as we have mentioned earlier, subretinal drusenoid deposits increase the risk of type 3 macular neovascularization. To recap the salient points, age-related macular degeneration or AMD is a progressive degenerative disorder of the retinal pigment epithelium and the photoreceptors, characterized by extracellular deposits beneath the RPE and/or the retina, which can evolve into either atrophy of the retinal pigment epithelium, retina, and the choriocapillaries, or neovascularization in the choroid and/or the retina. AMD is a leading cause of irreversible visual loss in older people worldwide. AMD can be classified into an early non-neovascular phase characterized by Drusens and RPE pigmentary abnormalities, and an advanced phase which can be further subclassified into two types: geographic atrophy or advanced non-neovascular phase of AMD, and macular neovascularization or neovascular phase of advanced AMD. Most common form of AMD is non-neovascular, but 85% of severe visual loss from AMD is due to macular neovascularization, which develops rapidly within days to weeks. Geographic atrophy contributes to 15% of severe visual loss from AMD and develops slowly over months to years. Non-modifiable risk factors of AMD include age, race, hyperopia, light iris color, elevated levels of inflammatory markers such as C-reactive protein, family history of AMD, and genetic factors. The two susceptibility genes are complement factor H and ARMS2-HTRA1. Smoking is the most important modifiable risk factor of AMD. Others include hypertension, atherosclerosis, cerebrovascular disease, Western diet, and obesity. AMD occurs due to accumulation of extracellular deposits in the sub-RPE space, mostly remnants of metabolism of components of photoreceptor outer segments in the retinal pigment epithelium. Accumulation of these deposits in the sub-RPE space decreases transfer of nutrients from choriocapillaries to the retinal pigment epithelium and the outer retina, resulting in relative hypoxia of retinal pigment epithelium and outer retina, which then secrete vascular endothelial growth factor A, or atrophy of these tissues, namely the retinal pigment epithelium and the outer retina. Age-related changes in outer retina RPE and Bruch's membrane include reduction in the number of photoreceptors, decrease in melanin, and increase in lipofuscin and melanolipofuscin in the retinal pigment epithelium, thickening and accumulation of lipids, collagen, and calcium in Bruch's membrane, and reduction in the vascular density of choriocapillaries. There is also a decrease in the average total choroidal thickness. In AMD, RPE cells lose their phagocytic capacity with loss of apical villi and basal infoldings. Amount of lipofuscin also increases. Dead and degenerate RPE cells slough off in the sub-RPE space, subretinal space, or even into the retina, and surrounding relatively healthier RPE cells expand and take their place, ultimately resulting in RPE atrophy. And following RPE atrophy, the underlying drusen may collapse and disappear. In AMD, between the RPE and the Bruch's membrane, two types of basal deposits are found. Basal laminar deposit occurring between the RPE and the RPE basement membrane, and basal linear deposit occurring between the RPE basement membrane and inner collagenous zone of the Bruch's membrane. These basal deposits, along with RPE degeneration, are the pathologic hallmarks of AMD, but these basal deposits are not detected clinically. The two types of drusen which increases the risk of advanced AMD are soft drusen and subretinal drusenoid deposits, also known as SDD. Soft drusens are focal accentuations of basal linear deposit occurring between RPE basement membrane and inner collagenous zone, whereas subretinal drusenoid deposits occur in the subretinal space. Soft drusen increase the risk of type 1 macular neovascularization, whereas SDD increases the risk of type 3 macular neovascularization. But both SDD and soft drusen can also lead to geographic atrophy. In geographic atrophy, there is a well-defined region of atrophy or absence of retinal pigment epithelial cells with loss of overlying photoreceptors and loss of underlying choriocapillaries. In an area of geographic atrophy, glasses of Muller cells may result in addition of the remaining overlying retina to the underlying Bruch membrane. Macular neovascularization are of three types. Type 1 originates from the choroid and lies in subretinal pigment epithelial space. Type 3 originates from deep retinal capillary plexus but may extend posteriorly to subretinal or subretinal pigment epithelial space. Type 2 macular neovascularization lies in the subretinal space and usually originates from the choroid like type 1 MNV and less commonly from the retina. Maturation of fibrous tissue associated with macular neovascularization results in scar formation with regression of the new vessels. Thank you for listening.